this preoperatively. And the preoperative IOP measurement, gonioscopy, UBM, B scan are important. And if the anterior chamber is shallow, a peripheral iodotomy should be done. Proper patient counseling regarding intraoperative complications is important. You should take precautionary measures to counteract the uveal effusion. Beveled incision and longer corneal tunnels are important, and never overinflate the anterior chamber. The careful and gentle hydrodissection is very crucial, and avoid anterior chamber phacoemulsification, and avoid frequent chamber fluctuation and shallowing to reduce the incidence of uveal effusion. And IOL should be ideally placed in the bag, and a peripheral iodotomy should be done. Now this patient had iris coloboma and retinochoroidal coloboma, and she also had a very small eye, and the axial length was less than 21. In addition to this, she also had a small peripheral synecdoche in the infratemporal quadrant. So beveled incisions were made, and trypan blue should be only little trypan blue you should inject so that it doesn't go through the colobamatus area and stain the vitreous. And after this, as you can see, when the rhexis was initiated, the entire bag lens complex was moving. So zonual weakness is very common in eyes with coloboma. So we should be mindful about this and should take adequate precautions. So after clear cornea incision, a gentle hydrodissection was done, and take care not to inject so much of fluid, but even with careful hydrodissection, there was iris prolapse through the clear cornea incision, so it was reposited. Whenever you are introducing phacoprobe through an incision where there was already iris prolapse, you should switch off the irrigation and then introduce the phacoprobe. And once you reach the eye, you have to switch the irrigation on. Now again, the phacoemulsification was done with low motion phaco was done. And during aspiration of the last piece, so OVD was injected to prevent sudden chamber collapse. During aspiration of the epinucleus, you can see the entire bag was moving. So I had to keep a Sinskey hook beneath the phacoprobe to prevent aspiration of the entire bag. So it was done very slowly. And then, as you can see here, the cortex was very sticky. It was not coming at all. This is because of the lack of countertraction by the healthy zonules. And once the OVD was injected, the anterior rhexis margin started moving centrally. This again is an indication of severe zonual weakness. Triamcinolone was injected, and there was no vitreous in the anterior chamber. So a CTR was placed to give equatorial support to the capsular bag, and this will strengthen the zonules all around. And after this, a 29 diopter lens was implanted. A single piece foldable lens was implanted inside the bag. As you can see here, this lens was almost filling the entire eye. And then this was carefully dialed into the capsular bag. Now in this patient with coloboma, she had a mature intumescent cataract, and the anterior chamber was very shallow. So here rhexis is going to be difficult because of two reasons. Because there is lack of red reflex is there, and there is high intra-bag pressure with a convex anterior capsule. So you should nicely fill the anterior chamber with OVD so that the anterior capsule is flattened. And first I made a small primary rhexis, and then once always try to pull it centrally so that the rhexis doesn't extend to the periphery. And once the cortex was aspirated, there was this black cataract beneath. And so to improve visualization, here also iris hooks were used, and a tangential cut was made on the rhexis, and this was enlarged secondly. Throughout this rhexis maneuvers, you should always fill the anterior chamber nicely so that it is pressurized and the rhexis doesn't extend to the periphery. Now while trenching and dividing the nucleus, see the nucleus slightly got tilted, and then because there was less space, it produced a large posterior capsule dehiscence. So I decided to convert it into SICS, and a new scleral tunnel was made, and this was taken out, and could see a large split in the posterior capsule. So anterior vitrectomy was done to clear the vitreous from the anterior chamber, and after
Thank you, Dr. Sandhya. I invite Dr. Thomas sir to give away the memento to Dr. Vinita.
Good morning, all. And even a cataract surgery is the most common surgery in the world. And an uneventful cataract surgery needs to initiate a modify or oral, topical, and periocular or intraocular medications for achieving optimal visual results. And we, are- our perioperative medications are very important. And for this, we will have perioperative antibiotics and oral topical intracameral in BSS. We have Dr. Gopalas Pillai. I think he needs no introduction. So, over to you, sir.
Thank you very much, Rajesh. That is not the presentation. The second, Dr. Gopal. Yeah. So since we have lost some time, I think I will finish quite early. So we are looking at perioperative antibiotics for cataract surgery. As we know, endophthalmitis is the worst possible complication anybody could have after cataract surgery. It will be severe inflammation of intraocular tissues caused by bacterial or fungal etiology during or after cataract surgery, which occurs within 1 to 2 weeks. Usually within 1 to 2 weeks, but it can occur later also. It is significantly poor visual outcome, and that jeopardizes the whole cataract surgery and jeopardizes carriers and behavioral pattern of surgeons and psychology of surgeons. It can have a huge impact. So it presents with visual acuity loss and sudden loss of vision. So this is the prevalence of endophthalmitis across different countries. In the UK, it's about 0.02. India, it's about 0.02. US, it's slightly higher, 0.06% according to the IRIS registry. So these are with moxifloxacin and with cefuroxime, etc. So these are with the intracameral antibiotics that we are having these figures now. So what are the risk factors for higher incidence? One is clear corneal incisions, about 5 times higher. Complicated long procedures, diabetes, uveitis, immunosuppression, posterior capsule rupture, old age. So we have a 5 times reduction with intracameral antibiotics. That's the first thing that we have. So basically, to prevent endophthalmitis, we require antisepsis. Povidone iodine is what is recommended, 5 to 10%, 3 minutes before surgery. We should know that the contact time of betadine is about 3 minutes. So there is no point in washing the eye with concentrated betadine and washing it away immediately. You should let the betadine be there for 3 minutes. Intracameral antibiotics, cefuroxime, has been proposed by the ESCRS, and moxifloxacin is more used in US and Asia and in India as well. Surgical technique, scleral tunnel offers lesser end-off as compared to clear corneal, especially in novice surgeons. Minimize surgical complications and use hydrophobic IOL over hydrophilic IOL. Topical antibiotics are actually supplementary, less evidence of efficacy, but generally it is used. So perioperative topical antibiotics, there is actually limited evidence. No high quality RCT demonstrates clear benefit of topical antibiotics, but 73% of people use preoperative antibiotics, and but it reduced from 85% in 2014 to about 73% in 2021. This is about preoperative antibiotics. Many people use 3 days before, many people do use 1 day before. Some people actually start the patient on antibiotics once they come into the theater. There's a lot of difference because there is limited evidence to its efficacy. But definitely do not miss povidone iodine. There are some concerns actually. Risk of antimicrobial resistance will occur because it will go into the nasopharyngeal flora. Intravitreal injections is even more a problem because the patient is receiving again and again and again. Weak, absent evidence of efficacy and patient compliance issues. Now, what about intracameral antibiotics? That is the gold standard. ESCRS in 2007 advocated, with level 1 evidence. They said that cefuroxime is very good, 5-fold reduction. Without cefuroxime, the incidence of end-off was 0.33. With cefuroxime, it reduced by 5 folds. And 66% of the cataract surgeons worldwide use intracameral antibiotics, which is up from 30% in 2007. Available intracameral antibiotics include cefuroxime, moxifloxacin, and vancomycin. So these are the available intracameral antibiotics. So ESCRS guidelines is about cefuroxime 1 milligram in 0.1 ml at the end of surgery. There are different techniques of injection. Some people hydrate and then inject. There are different techniques. Recommends, Royal College of Ophthalmologists recommends again intracameral cefuroxime. And American Academy basically looked at moxifloxacin. Basically, it will be at the end of surgery, and avoid gentamicin, vancomycin, etc. All right. This is the famous study from Haripriya in Arvind, in which the incidence of endophthalmitis, significantly dropped down from 0.2 to about 0.09. So that is the significant drop in the endophthalmitis rates once they started using intracameral moxifloxacin. So antibiotics in irrigation was used once upon a time, but you can see the declining practice. By 2021, only a minuscule number of people, probably older people who do not want to change the religious practice, believing that that may give some fringe benefit to the patient, is using that. Oral systemic antibiotics, there is limited intraocular penetration, so there is no evidence of efficacy and can lead to resistance. So guideline consensus is no need for systemic or oral antibiotics in a usual scenario. But in high-risk scenarios like severe immunosuppression, active infection, then generally we would avoid cataract surgery in an active infection. Now, so finally, evidence-based best practice: 1, povidone 5 to 10%, 3 minutes contact time. Intracameral antibiotic, cefuroxime. This has high level of evidence. So, whereas, preoperative or post-operative antibiotics do not have significant evidence. It is optional, weak evidence, but generally all of the ophthalmologists use it. Irrigation bottle antibiotics, usually very less evidence or weak evidence. Not recommended would be oral systemic antibiotics, vancomycin or nasal decolonization with mupirocin and stuff like that. Thank you very much. Next in, I will invite Rajesh to talk about pericataract surgery, steroids and NSAIDs. What is the choice, frequency and duration?
Good morning. As you know, cataract surgery is one of the most performed elective surgical procedure, and surgical methods, improved surgical methods, and has significantly decreased the complication and increased patients' and surgeons' expectations. And cataract surgery induces surgical inflammatory response, and post-operative uncontrolled inflammation can lead to complications such as corneal edema, IOP spikes, and systemic macular edema and posterior capsular opacification. And uncontrolled inflammation may lead to serious side effects such as posterior synechia, uveitis, and secondary glaucoma. And NSAIDs and steroids form major armamentarium for the cataract surgery, and it has got prevention. NSAIDs has got a role in ocular inflammation and prevention of intraoperative meiosis and CME. Steroids play a role in controlling inflammation. And NSAIDs work by inhibiting cyclooxygenase enzyme, and the cyclooxygenase enzyme catalyzes the release of prostaglandins and thromboxanes, and prostaglandins mediate inflammatory reactions. Hence, NSAIDs has an important role in cataract surgery. And it also helps in reduce pain and prevent intraoperative meiosis and modulate postoperative inflammation and reduce the incidence of macular edema. And studies show that when it is used with steroids or alone, when NSAIDs are used alone, also rate of CME is less. And depends on the risk of the patients. Post-operative topical analysis do not significantly improve the post-operative best corrected visual acuity, reduce the rates of CME, or improve patient-related quality of vision compared with placebo. But NSAIDs significantly reduce the rate of CME and improve best corrected visual acuity, and also central macular thickening also in diabetic patients without retinopathy. However, the data regarding benefits of NSAID use in diabetic retinopathy is a conflicting data. Postoperative NSAIDs play a role in postoperative inflammation. And these are the medications. We have bromphenic, indomethacin, diclofenac, flurbiprofen, Cataract, and napafenac. And the risk factors for postoperative CMEs are contralateral CME, posterior capsule rupture, epiretinal membrane, macular hole, uveitis, retinal vein occlusion, retinal detachment repair, and diabetic. These are the conditions we require NSAIDs and the proven benefits with NSAIDs. And preoperative studies regarding preoperative non-steroidal anti-inflammatory drug use. Many cataract surgeons begin NSAIDs medication for the postoperatively to reduce intraoperative prostaglandins and blunt postoperative inflammation. Postoperative NSAIDs use prevention of cystoid macular in low risk patients. Recent studies demonstrated that significantly lower central macular thickness measurement in patients who use the Cataract compared with the diclofenac, and bromphenic when compared with the napafenac, equivalent postoperative measurement for Cataract and napafenac. And no studies demonstrated superior postoperative best corrected visual acuity or reduction in incidence of CME in patients with a low preoperative risk. According to preferred practice of American ophthalmology, the perioperative prophylactic NSAIDs for prevention has been advocated for high-risk patients. However, there is no level 1 evidence for this. Patients with a diabetic retinopathy, NSAIDs, however, did not show significant reduction. And hence, the suggestion is Cataract, we can start 3 days prior for Cataract or flurbiprofen, and napafenac for 8 weeks, or bromphenic. And complications are burning and conjunctival hyperemia, keratopathy, corneal melts, severe allergic reaction, and cross reactivity. And next is steroid and anti-inflammatory action, non-specific occurring, whether etiology or allergic or infections, and reduce histamine. This is the mode of action. And side effects are ocular hypertension, retardation of epithelial healing, keratitis, corneal thinning, scleral thinning, mydriasis, ptosis, and transient ocular discomfort. And these are the medications available in prednisolone acetate, prednisolone sodium phosphate, dexamethasone, and dexamethasone sodium phosphate, fluorometholone acetate. And prednisolone 1% has greatest efficacy and has greater but has got a greater chance of IOP rise. And dexamethasone is also a potent steroid, but it is resistant to metabolism after penetration of aqueous humor. Hence, there is a chance of increased IOP, and fluorometholone is relatively weaker. And so, suggestion is we can start prednisolone initially, and studies shows that if 3 weeks it takes up to 3 weeks to increase the IOP. So we should start tapering by 3 weeks. Thank you. Call upon Dr. Midun Tulasidas for regarding modification of perioperative anti-glaucoma medications.
Thank you, Rajesh sir, for giving me the opportunity. So I'll be talking on modification of perioperative glaucoma medications in cataract surgery. So I'll be discussing this presentation under 2 subheadings: why do you need to modify the perioperative medications, and the overview of situations where glaucoma and cataract can coexist. So the basic rationale for modifying glaucoma medication is to prevent drug-induced inflammation or surgery-related complications and reduce perioperative IOP spikes. So as you can see in this figure, the figure B is basically a pseudophakic cystoid macular edema where you can see more cystic spaces in the nuclear layers compared to the figure A, which is the diabetic macular edema. So the basic question for which we all want answers is whether to hold prostaglandin analogs and carbonic anhydrase inhibitors. Now the only glaucoma drug which actually should be stopped before cataract surgery is pilocarpine, because it can induce meiosis and can cause drug-induced inflammation. So this drug should be stopped at least 3 days to 1 week before the cataract surgery. Coming to prostaglandin analogs, how does this work in causing inflammation? It is by forming endogenous prostanoids which may result in the breakdown of blood-retinal barrier leading to fluid leakage. However, there is no evidence that you have to stop PGAs in all cases of routine cataract surgery, and there is no clinical significant effect on reducing postoperative CME by discontinuing PGA. So this can be continued in routine cataract cases, but can be discontinued in risky cases where you are suspecting a postoperative inflammation like in a uveitis, subluxated traumatic cataracts, or even in PPC or those with retinal pathologies. Again, it's a clinician's choice. If you are stopping it, it is preferably to stop at least 4 weeks before the surgery based on the washout period, because we have seen a lot of cases where the PG analogs will be stopped 1 week before surgery, then it will remain in the eye. So there is no point in stopping it very recently. If you're stopping it, you have to stop it at least 1 month before the surgery. Carbonic anhydrase inhibitors, as the name indicates, it inhibits the carbonic anhydrase enzyme in the corneal endothelium, but all these are mostly in vitro studies. We don't have much evidence in human eyes, and this can compromise the sodium potassium pump and lead to corneal edema. There are varying results in the literature. Some say it can increase the corneal thickness, some say there is no change. It can decrease the endothelial cell count or no significant difference. So there are different contrasting results in the literature. Better outcomes with brinzolamide are published compared to dorzolamide. So again, carbonic anhydrase inhibitors can be continued in routine cataract cases, but should be carefully considered only in corneas with reduced functional endothelial reserve. And this can be stopped 1 week before the surgery based on the washout period. No consensus regarding the use of other anti-glaucoma medications preoperatively. However, the topical and systemic side effects associated with each should be considered. What if the real culprit could be back actually? Because even though we are saying it is prostaglandin analogs causing the CME, there is studies which say benzalkonium chloride, which is a preservative which is used in most glaucoma medications in earlier days, it can disrupt the blood aqueous barrier and can cause direct cytotoxicity, dose dependent damage, and compromise barrier function. But nowadays we have other preservatives and even preservative free glaucoma medications which would be preferable in patients planned for cataract surgery. Hyperosmotic agents we usually give in cases where you are anticipating some challenges or complications during the surgery, especially in short eyes. I usually prefer giving it in axial length less than 21 millimeters of mercury, or in cases of lens-induced glaucoma where the preoperative IOP is more than 40. But make sure that the patient visits the restroom after giving mannitol before shifting to the OR, because whatever reduction of IOP you do, if the patient exerts external pressure on the table, that can lead to complications. So make sure the patient visits the restroom after giving mannitol. Acetazolamide can be given, again it's a clinician's choice, in early glaucoma or pseudoexfoliation cases. But if you're giving, it's always better to give it preoperatively rather than postoperatively, because preoperative administration is found to decrease the elevation from 1 to 2 hours, that is the immediate postoperative period. However, if you're administering it postoperatively, the action comes only after 5 hours, and this was published by Hayashi in Ophthalmology. Intraoperative considerations, as we all know, the main consideration is the AIRES, that is the acute intraoperative rock-hard eye syndrome. So you have to deal with it. You have to make the hyperosmotic agents in your armamentarium and make it ready. Postoperatively, you have to actually monitor the IOP, and you should restart or adjust the glaucoma therapy. Now, which is the fastest acting anti-glaucoma medication? So it is found to be carbonic anhydrase inhibitors followed by beta blockers. So a combination of CIA and beta blockers would be useful if you want to control the postoperative IOP spike immediately, because they work at 2 hours at the peak onset. So brinzolamide is found to reduce the IOP more than travoprost or timolol after cataract surgery in this study by Ayashi et al. Published in American Journal of Ophthalmology. So you can always consider carbonic anhydrase inhibitors if there is no corneal endothelial damage, or a combination of beta blockers with carbonic anhydrase for postoperative IOP spikes. Now the new kid in the block, that is a ROCK inhibitors. As we all know, it has a few extra advantages in other structures of the eye, mainly cornea, because it increases cell proliferation and adhesion and can be useful in cases with corneal edema. But beware of the side effects, because we had cases where there was bilateral contact dermatitis due to natacidil and a honeycomb appearance, but all these side effects are reversible once you stop the drug. Considering the safety profile, rapasudil is definitely better than natacidil. Can restart the PG and pilocarpine after 4 weeks. So to conclude, perioperative modification of AGM is essential to ensure safe surgery. PGAs and carbonic anhydrase can be continued in routine cases. However, the postoperative therapy should be individualized based on inflammation, IOP status, and associated comorbidities. Thank you for your attention.
Next, we have use of anti-VEGF agents in cataract surgery, choice and timings. Dr. Srinivas Joshi, he is a member of All India Ophthalmic Society ARC South Zone, and he's a trained vitreoretinal surgeon and expertise in adult and pediatric retinal pathology, and he has been internationally recognized for his contributions. Over to you, sir.
Thank you, Dr. Rajesh, for including me in this IC. Thank you, entire office bearers of KSOS, for hosting a wonderful function. So I'll be talking on the uses of anti-VEGFs in the cataract surgery. So we all know that 7.5 million cataract surgeries are done annually. So why do we need to know about this? Because of the coexisting retinal pathologies, whether it's a diabetic macular edema, AMD, PDR with TRD, or retinal vein occlusions. So what happens if we do the cataract surgery without giving anti-VEGFs in a case of PDR with TRD? They usually progress more. The tractional retinal detachment sometimes will progress more. Retinal vein occlusions, pre-existing macular edema will exacerbate. Intensify the AMD activity. This is not actually proven. There is still a debate over it, but we'll think over it that, okay, it can accelerate the progression of dry AMD to wet AMD. And of course, diabetic macular edema is already established that the cataract surgery progresses the diabetic macular edema. So why do we need anti-VEGFs? In all these 4 conditions, again, what is the only one Ramabana what we can say is anti-VEGF, as it's a crucial adjunct in the cataract surgery to minimize the intraoperative complication and also to maximize the visual outcome. So what is the mechanism of action? I think we all know about it. I'll not go into the detail, but most of these are receptor blockade. You know, what of bevacizumab, ranizumab, VEGF trap, faricimab, all these, they block extracellularly. The rest what they are planning is intracellularly. Of course, they have not come into the market, but good to know that there are tyrosine kinase signaling blockade which prevents the angiogenesis to happen. So these are the various anti-VEGFs available in the market today. And what are the choice of the anti-VEGFs? Yes, that's very important. Avastin, yes, definitely 70% of the country still uses. The only thing is it's off-label drug. Ranibizumab is still the gold standard. Aflibercept Eylea is definitely a better injection, but patient should have some good paying capacity. And brolucizumab Peginex is like a bomb. It's a very good activator because it has around 11 to 12 proteins per molecules per vial. So that itself shows that it is a very strong drug, but of course it has its own side effects. And faricimab, Vabysmo, which has now come, these are the longer acting anti-VEGF agents. So if you look into the efficacy, all approved agents show similar efficacy almost. I'm not going into the head-to-head trial. Cost and availability, bevacizumab is lower dosing, and if the patient is less affordable, then you can give frequent monthly injections, or if they are affordable, you can go for the longer acting injections. What are the timing of the anti-VEGFs? That is very, very important. Preoperatively, In case of PDR with TRD, we usually give at least 1 week prior to the surgery. So that minimizes the bleeding intraoperatively. And of course, intraoperatively, if you have not planned vitrectomy, there is a macular edema, then you can plan both diabetic cataract surgery along with the anti-VEGF injection. The only thing is, if you are planning with Paginax or brolucizumab, then we don't combine both together, because the brolucizumab is known to incite the inflammation. So we don't combine that. But rest of the injection can be given, including Ozurdex, Dex implant can be given along with the cataract surgery. Advantage, the patient come one, both the things can be done at the same time, and then patient can go back rather than get an injection. But there are other theories which they say that first try to minimize the diabetic macular edema and then go in for the cataract surgery. Both can be done. So now looking preoperatively in case of PDR, now you can see here what happens if you leave late. The patient receives injection and he doesn't turn up or comes after a month. So this is the problem happens, what is called as the crunch syndrome, which is very dangerous. If the patient vision drops down, it's very difficult to get it back. So we have to be very careful. I'll just show a few of the videos where we used anti-VEGFs, we did not use anti-VEGF. So here you can see the anti-VEGF was used. Now, of course, I'm using a different filters in the Ingenuity, that is the, I don't want to speak more on that, but what is important here is, see here, the PDR, I'm cutting the membranes, I'm using a green channel of the Ingenuity, there is minimal bleed at all. You can see that helps the vitreoretinal surgeon to dissect these membranes easier and get rid of these membranes more better, so that you have less iatrogenic breaks, lesser iatrogenic breaks. This is the post-op picture of the same patient. Now let's look into another case where anti-VEGF agent was given, but given only in the form of 3 days. So what happens here? Do you see, cycling through the different custom filters. Now I'm using again, I'm not going to talk on the filters, but here you can see here, it is a bloody red situation. So that's why I had to change the filters here, so that the blood get masked, the red color get masked, so that I can peel these membranes pretty much easier. Now you see here, I'm just, kind of fluoresce. The fluorescence kind of things gets activated with these membranes. But when I come to the normal mode, see here, this is how the blood keeps happening. So the prodigious use of anti-VEGF before the surgery is very, very important for the vitreoretinal surgeons. Now coming to the next, this is the diabetic macular edema, where I used anti-VEGF before and then went ahead for the cataract surgery. So what happens in these cases where there is a very thin ILM, then while peeling the ILM, the de-roofing can happen. So subside the diabetic macular edema or the cystoid macular edema and then go in for the vitreoretinal surgery. So again, we're doing a cataract with vitreoretinal surgery. So what I do in these kind of cases, I always tell my anterior segment surgeon, first do the cataract surgery, give an anti-VEGF injection. I will take care of the retinal part after a week. Two-stage procedure, why important? Intraoperative meiosis, again a problem while doing a vitreoretinal surgery if you are climbing it on the same stage. And second thing is, you give some time for the anti-VEGF, because we need anti-VEGF to work. So at least 8 to 10 days time is given. So by that time, post-cataract surgery, you will have a stable chamber. When I'm indenting, I don't want any of these ports to open up and the iris keeps coming out through that port. So these are the several various advantages of using the anti-VEGFs along with the cataract surgery and plan the vitreoretinal surgery later. So this is the same case which I want to show here. See here, this is a small drape of ILM. Now you see there's completely the post-operative along with the anti-VEGF agent. So phaco, yes, phaco does not increase the ERM progression. And this is the case of DME. As I was talking about here, what we did was, did the cataract surgery and the anti-VEGF agents both together, or you can give anti-VEGF agents before and then plan the cataract surgery. Either of thing can be done. But only in case of, if there is, say for example, the PDR, in these cases the laser has to be done, anti-VEGF has to be given, and then plan for the cataract surgery. Otherwise the bleeding chances might increase. That is very, very important. So caution has to be exercised, because the reports have shown that multiple use of anti-VEGFs also causes risk of retained lens fragment, probably because of the lens touch, which happens because of the, and endophthalmitis rates have also increased, is what these publications say. So to summarize, I think judicious use of anti-VEGF important, collaboration, that is between the cataract and retina specialist, is of paramount importance. Thank you very much for the patient listening. Thank you for the opportunity. Thank you.
Yes, sir. And I call Dr. Anil Radhakrishnan, sir, for a talk on management of dry eye, meibomian gland dysfunction and associated symptoms. Dr. Anil Radhakrishnan is currently serves as consultant cornea and refractive surgery at Amrita Institute of Medical Sciences. Thank you, sir.
Okay, thank you for the opportunity. So, if you have something like this, a pterygium, I think this is distorting the central cornea. Better to get the pterygium out and then do cataract surgery. If it's a very early pterygium, maybe you can leave it. So this is topography before and after pterygium surgery. You see the amount of flattening that is caused by the pterygium. So your K values can really go wrong. The other thing that we consider is the dry eye that is associated with cataract surgery. I will not go into the details of the lacrimal function unit, but something more important is the perception of pain that we get. You know, there is a thalamic center for pain. And there are 4 processes of any pain. The first is the transduction, then transmission across the spinal cord, then modulation that happens in the brain, and then the perception. So that is very, very important in the perception of the post cataract surgery dysesthesia. It may not really be dry eye. So preoperative planning, we should look at the K values. If the keratometry is showing, if you see some random spot like this, it is likely that the patient has got a dry eye. This patient, after putting an artificial tear, the K values are normal. So what is the impact on dry eye on the preoperative planning? Obviously, the cataract surgery calculations, K values can go wrong. Even your toric axis can be wrong. So if you look at the patient in a diffuse illumination, you may not exactly detect it. Just put a fluorescent drop and see, or see a parallelepiped image, you can see the punctate erosions. So this is something very useful. Is it a video? Can you click on that? Yeah. So tear breakup time, just put a drop of fluorescent and see, nothing else. You don't need any sophisticated diagnostic equipment to diagnose this. If you see that the tear film is spontaneously breaking up, like in this patient, I don't know whether you can really appreciate. I can see it in the monitor over here. So you know that the lacrimal status is not great. So you have to tackle the dry eye properly before you take the patient for cataract surgery. There are a lot of drugs. A lot of old people use the Parkinsonism drugs, antidepressants, beta blockers are also very commonly used. All these things can either augment or cause dry eye. And even long-term diabetes will cause some amount of neuropathy, which will cause the dry eye. And obviously, connective tissue disorders are associated with dry eye. So all these things will add to dry eye, and you have to be aware of that. So you don't need any dedicated mammography device. Even your autorefractometer or your OCT machine, you can flip your lid and see the meibomian glands, and that is an indicator of the status of the meibomian glands. Is dry eye common? That is a very important question. The companies keep saying that every patient you have to give this lubricants before and after cataract surgery. So this is one of the largest meta-analysis in which they have looked at 9 studies and about 775 patients. So what they saw is that around 37.4% developed some amount of dry eye, and mostly the factors that were incriminated were the incision, the long exposure time during surgery, and the prolonged use of betadine. I'll just touch upon the corneal bloods, the nerve supply. Cornea is one of the most densest part of corneal innervation that you can find in the body. It has about 4,000 to 7,000 terminals per square millimeter, highest in the body. So any cut in the corneal nerve will cause lack of corneal sensation. After LASIK, your corneal sensation comes to normal after about 6 months. After keratoplasty, more than a year. And after cataract surgery, at 1 month, you are likely to get the maximum dry eye. That is because the neurite cells emerge, and there is a stark increase in the neural growth factors at about 25 days. And that is the time period where you get the maximum symptoms. So what actually happens during cataract surgery? You have a cut in the cornea. It may be a small cut. It's hardly 2.5 millimeter, but still it causes denervation of the cornea to some extent, and that can impair the wound healing, epithelial permeability, and all that. And so that can lead to some amount of dry eye. So what are the factors that are important? One is the type of procedure. If it is a phaco, it is a small wound that you are causing, that is less likely. If you have a large wound like SSCS or an ECC, you are cutting across a lot of nerves, and so the chance of dry eye is more. the type of ophthalmic solutions that you use inside the eye, intraoperative medications. Betadine also, Gopal was stressing about the need for putting for 3 minutes, but don't put too long. It can be epitheliotoxic. Operating light exposure also, you don't keep it at maximum brightness, which is comfortable to you. The minimum possible brightness is best. Then coexistent disorders should be taken care of, and the timing of the surgery is also important. If you operate for more than half an hour, the chance of dry eye is more. And to some extent, the cumulative dissipated psychoenergy is also important. So the only thing that you have to see is just put a drop of fluorescein and do a tear breakup time. If the tear film is breaking up soon, or if there is a corneal staining, definitely you have to defer cataract surgery. So if it's a mild dry eye, you can go ahead with the cataract surgery. You can't postpone it for a long period of time. So use some artificial tears. It is better to use it preoperatively also. And better to use something such as a hyaluronic acid or a combination of hyaluronic acid or PPG, or even better would be hyaluronic acid plus trehalose. It takes about 1 month for the dry eye symptoms and the signs to improve, actually. That is what the evidence says. And if you are prescribing omega-3 fatty acids, don't give just BD and all that. Give less than 1 gram, it does not work at all. So 1.5 grams should be given. So there are studies, I think industry-driven studies, but they compared 3 groups. One group in which no medications, the dry eye scores were maximum in the group C. That means no postoperative lubricants were given. In the first group, preoperatively they gave lubricants, and postoperatively also lubricants was given. In the group B, actually, it was only given in the postoperative period. So the dry eye scores are the least in whom we use preoperatively also. So in my practice, what I've seen is around 20 to 25% of people get dry eye after cataract surgery. And especially in predisposed people, I definitely give preoperatively some good lubricant. So we were telling about the incisional damage you do at micro-incision cataract surgery, and in a patient who has got a dry eye, better to avoid astigmatic keratotomy. I'll just take 1 minute. Then limit the drop exposure. Your nurses will keep on putting the dilating drops. Don't do that. That can cause epitheliotoxicity. Then even povidone single drop application is better. Preservative-free drops would be better. If you can give preoperative lubricants, especially hyaluronic acid and PPG, it would be better. Then while during surgery, consider coating the ocular surface with a dispersive viscoelastic agent. You do it only 2 or 3 times during cataract surgery, and that should be enough, rather than putting drops, keeping on pouring every time. Reduce the surgical time by reducing the microscope illumination, and don't use excessive illumination, and limit surgical trauma as much as possible. And if you're doing femtosecond cataract surgery, suction ring, if you take multiple suction rings, take it in and out, there can be more damage to the structures, and there can be more dry eye. So in the case of a moderate to severe dry eye, we have to use cyclosporin, omega-3, sometimes even lacrimal plugs. So we have to defer cataract surgery. We give this cyclosporin. The effect will come after only 3 or 4 weeks. You give good lubricants, something containing hyaluronic acid and CMC, or hyaluronic acid plus PEG plus HP-GOR, that is a stain or something similar. And wait for some time, 3 to 4 weeks, and then only consider cataract surgery. Always a good idea to start cyclosporin and omega-3 fatty acids also. If it is a severe dry eye, you have to look for collagen vascular diseases. Look at ESR and CRP at least, and if it is high, have a rheumat consult and get it under control, and then only do cataract surgery. And in certain situations, you have to give systemic steroids also. This is a patient with rheumatoid arthritis. After cataract surgery, he developed a corneal melt. We did a lacrimal plug and just gave systemic steroids, and it got better. In SJS, the situation is different. It causes wipeout of the meibomian glands and margin keratinization. So it's quite often you see that the meibomian glands are very low. And in such situations, you have to be very careful. You always can do a punctal cautery, which can be like a plug. It is a permanent plug, which can be followed by a phacoemulsification. In OCP with adherent leucoma also, better to do a phaco. If you have PUK, the disease has to be under control before you attempt any cataract surgery. This is a patient who had a PUK, had the disease under control, had a crescentic lamellar keratoplasty, and had a cataract surgery. So, cataract surgery is universal. Dry eye is universal after cataract surgery, and the treatment of dry eye is demanding, and optimization of ocular surface is important to ensure a good surgical outcome. Thank you.
Thank you, sir. Regarding medical management and to prevent posterior segment complication, including endophthalmitis and TAS and CME, we have Dr. Prithvi Chandrakant. He is a vitreoretinal surgeon at Chandrakant Netralaya, Kozhikode. Over to you, sir.
Thank you, sir. Good afternoon, everybody. Good morning, everybody. So I'll be talking about management of post-op endophthalmitis, TAS, and CMAs. As you all know, there's a post-op endophthalmitis is a severe vision-threatening intraocular infection, typically occurring following any ocular surgery, most commonly after cataract extraction with intraocular lens implantation. So it's considered as an ophthalmic emergency requiring prompt diagnosis and aggressive management to salvage vision and the globe. So first of all, the whole thing starts from the reception onwards. So we need to actually train the receptionists to triage these cases whenever they see some red eye and all these cases, to immediately take them to the doctor. So history of the eye surgery has to be taken, very important. And what are the red flags? Symptoms: blurred vision, redness, and eye pain. You can have photophobia, floaters, and lid swelling. So all these are red flag symptoms, and this is the classification that we have to learn, that is post-op endophthalmitis, 12 to 24 hours. It could be TAS also, so we need to differentiate between TAS and endophthalmitis. And then the acute endophthalmitis comes until 6 weeks, and more than 6 weeks it is chronic. So differentiating between TAS is, one thing is there is no infection and it's very rapidly onset, and it's sterile inflammation reaction, and vitreous will not be involved as much as the endophthalmitis cases. In acute endophthalmitis, more virulent, and patient ocular flora and wound related sources will be there, and it is very rapidly onset. These are all the organisms. In chronic, it is less virulent. Sources could be bleb related, lens matter, or any fungi. Low grade and slow progressive rather than the one in the acute phase. So task management, immediate recognition needs to be done within 12 to 48 hours. That could be diffuse limbal to limbal corneal edema, severe AC reaction, hyperpion, minimal or no pain, and clear vitreous. That is one differentiating factor which we have to look out for. And after immediate recognition, first 24 hours, you need to give topical eye drops, steroids, preferably prednisolone or difluprednate, eye drops of atropine for cycloplegic, and any agents like beta blockers or carbonic anhydrase. And if the cornea is involved, better to give a hypertonic saline also. And oral acetazolamide and avoid prostaglandin, because it could actually increase the inflammation. Post-op endophthalmitis, immediate action needs to be taken. Early management starts within the 15 to 30 minutes of suspicion. Earlier you diagnose, the earlier we can treat and salvage the eye. So the first thing, vision, light perception, and hand movements. This itself is the actual solution for our treatment also. So if it is light perception, immediate pars plana vitrectomy and antibiotics needs to be administered. If it's hand movements and better, always we can wait, or some people actually go in with the vitrectomy itself. IUP measurement has to be taken care of. If it is too high, it is always better to start AGMs. And then the signs and anti-segment, corneal edema, marked AC reaction, that could be hyperpion, and AC exudates, along with the sluggish, poor reacting pupil. And in the posterior segment, poor retinal view, vitritis, exudates and ischemia. There would be snowball exudates in fungal, and severe iridocyclitis, and retinal abscess in the later stage. And if you cannot have a good view of the retina, it's always better to have a B scan taken. So the next thing is antechamber tap. So this is a very important step, that before we start giving intravitreal or intracameral antibiotics, it's always better to take an antechamber tap. You need to go in with the needle and take a small 1.1 millimeter of Echo's tap, and vitreous tap also has to be taken. So again, the pars plana route, we take around 0.2 to 0.3 millimeter. And if you are anyway going to do a pars plana vitrectomy, always do a vitreous biopsy before you start the infusion. So always clamp the infusion and then do a vitreous biopsy. 0.2 to 0.3 ml has to be taken, and once that is done, you can start the infusion, and then you can do the core vitrectomy. So this is a step that needs to be done, and we can send it for smear and sensitivity and culture to get a more better idea of what organism is causing the end off, so that we can treat them better. These are all the most common organisms responsible for endophthalmitis. Gram positive is 75 to 85%, gram negative 10 to 15%. These are all the organisms, and in rare scenarios, fungal end off with these species can be seen. And in established endophthalmitis, antibiotics when given oral or IV have really poor penetration into the vitreous cavity. It is always better to actually go with the empirical therapy. Hence, intravitreal injection are the treatment of choice, and intravitreal injection rapidly achieves the therapeutic levels at the site of the infection. So this is very important. For gram positive, because most of the cases were gram positive, vancomycin was given. Thus, vancomycin 1 milligram is given intravitreally. Gram negative, gentamicin was used, but because of retinal toxicity, it was changed to ceftazidime. So this is the concentration over here. This is for covering of gram negative. And for fungal, we give voriconazole. Again, it will be 0.1 milligram per 0.1 ml. And if for inflammation, we can give the dexamethasone injections also. These are all the dosage of each medical medicine, intravitreal medicine that we give. Also, no financial interest, but there is a Orlab e-kit which is available. I think it is for 2,000 rupees, which has all the medicine at the proper dosage already there in the box. So this is something which every hospital has to keep at least 1 or 2 stocks in their hospital. If any case of suspected endophthalmitis comes, you can just open this and give. Any adjuvant therapy in the first 24 to 48 hours, systemic fluoroquinolones, cefotaxime, gentamicin, and voriconazole. Any topical therapies like fortified antibiotic drops, cycloplegic, topical steroids, lubricants, and supportive for pain, analgesics, any agents for IOP increase. And this is a basic clinical management of suspected endophthalmitis. Take AC tap, vitreous tap, and send it for culture sensitivity. It will come back within 36 to 60 hours. Re-evaluate and repeat the injections. So you can start the empirical therapy side by side. And if it's clinically worsening, you can also go again and give another antibiotic, intravitreal antibiotic. Or if it is worsening a lot, you can actually go in for a pars plana vitrectomy. Surgical management, if visual acuity is less than hand movements, or maybe failure of treatment of intravitreal empirical therapy, or progression of endophthalmitis, fungal endophthalmitis, and blood-related and trauma can always be taken as surgical management. Theoretical advantage is that removal of infection organism and their toxins, removal of vitreous membranes prevents TRD, and provision of adequate material for culture, better for distribution of antibiotics also. And then disadvantage, it is very friable, inflamed, so necrotic retina is there, so it is very difficult because any manipulation can actually go into complications like retinal detachment. These are all the sequelae that occurs. The prognosis with each organism, good with the coagulus negative, Staphyla aureus is moderate, the others are all poor. Candida species good to moderate. These are all the sources of each infection, each organism from where we get it. Staphylococcus from eyelid, most of it is in the ocular flora itself. And a few of them are Pseudomonas and Klebsiella can happen due to our hospital contaminated surgical instruments. And so all these things need to be taken care of. Risk factors and I think the other things were already told by Gopal sir. So thank you.